Pelo 8º ano seguido, a Unifesp foi reconhecida com nota 5, conceito máximo na avaliação do MEC. A Unifesp foi também destaque no ranking Guia da Faculdade, ficando entre as 10 instituições públicas com maior número de cursos 5 estrelas. Ela foi reconhecida pelo ranking da Times Higher Education 2023 como a 3ª melhor universidade do Brasil e como a melhor federal do país. São mais de 50 cursos de graduação e 70 de pós-graduação, voltados para as áreas de tecnologia, ciências exatas, humanas, biológicas e da saúde. Aqui é o seu lugar. Unifesp, universidade pública, gratuita e de qualidade.
Boa tarde a todos. Damos continuidade hoje ao nosso curso de atualização em cirurgia cardiovascular, no módulo Transplante Cardíaco, em associação com o Miami Transplant Institute, University of Miami. Hoje eu tenho o prazer de apresentar o Dr. Saji Kadhir, e agora eu vou falar em inglês para apresentá-lo. It's with great pleasure that I present to you Dr. Saji Kadhir. Dr. Saji Kadhir is a cardiac intensivist, and he's trained in both cardiology and critical care medicine at the Miami Transplant Institute. He will honor us with the lecture, Intensive Care Aspects of Heart Transplant. Dr. Kadhir, it's with great pleasure that I introduce and receive you today on behalf of the Cardiovascular Surgery Division of Paulista School of Medicine, Federal University of São Paulo. Thank you so much for having accepted this invitation, and feel free to start your presentation. Thank you again.
Thank you for the introduction. It's a pleasure to be here. Just want to make sure you guys are seeing my slides. Are we looking all right? You guys can see my slides easy. Today, I'm going to talk about the intensive care unit management of heart transplantation patients. And I have no disclosures for this presentation. And I just want to give you some pearls of critical care medicine that I've learned along the way. And part of what I do, we have a lot of evidence, a lot of anecdotal evidence and standard of practice. But most interventions really won't save lives unless they affect the mechanism of disease. And a lot of what you do in critical care is avoiding the deleterious or negative effects of therapy. And if you avoid the bad, support the patient, they can get better. And this holds true for inotropes, vasoactive medications, timing of dialysis, modes of mechanical ventilation. And we'll all go through a little bit of this within the context of heart transplantation. So let us start with a clinical scenario. This is just a typical phenotype, 45-year-old male, inherited familial dilated cardiomyopathy. He had his heart transplantation done and he transferred to the intensive care unit with a relatively uncomplicated operative course. He was a virgin stenotomy, no blood products given. His transesophageal echo showed some mild RV systolic dysfunction, while on 0.25 of milrinone, nitric oxide. His central venous pressure of 8 millimeters of mercury. His pulmonary pressures seemed normal, 22/12. His cardiac output and index of 5 and 2.5 respectively, while supported on milrinone. He has a sinus tachycardia, 110 beats per minute, which is a good heart rate for denervated heart post-transplantation. He's on mechanical ventilation, assist control volume control with a respiratory rate of 18, tidal volume of 420 cc's. His peak pressures are 28, plateau pressures are 22, and he's on 50% FiO2. Life seems good. Chest tube outputs very favorable. His coagulation, his TAG is normal. He's on low-dose vasopressin for tone support and dexmedetomidine for some sedation. And on arrival, his blood gas pH of 7.4, CO2 of 40, and his PaO2 seems pretty generous on 50% FiO2. So life is good. This is just a typical patient that you can have to recover. And today's objectives, we will touch on important high-yield topics such as hemodynamics, including graft dysfunction, post-op vasoplegia. We'll talk about heart rate and rhythm. We'll mention right ventricular dysfunction after heart transplantation. We will discuss mechanical ventilation, acute kidney injury, glycemic control, antibacterial prophylaxis, antiviral, antifungal, and antiprotozoal prophylaxis. I want to spend a couple slides talking about Fontan physiology within the realm of adult congenital heart disease, just to whet everyone's appetite that these patients would start presenting to the adult cardiologist and adult intensive care unit after heart transplantation. So what's graft dysfunction? Early primary graft dysfunction, or PGD, you have to understand that it's associated with increased mortality, both at 30 days and 1 year as well. And it's diagnosed within 24 hours of heart transplantation. All of these grafts have some type of dysfunction, and we learn how to classify them. It can be divided into left ventricle, right ventricle, or biventricular dysfunction. And I'll show you a nice table that helps you remember how to classify primary graft dysfunction. And you really categorize it accordingly, depending on the filling pressures, cardiac output and index, the extent of inotrope and mechanical support used. And it's particularly important to understand that isolated right ventricular failure could be pretty nasty and an independent risk factor for mortality, and we have to be aware of it. Let's move forward. So one would ask, why would we have graft dysfunction? There are many, many reasons, right? Why would we have problems potentially after heart transplantation? But cardiopulmonary bypass in itself, whether it's for heart transplants, whether you're doing open heart surgery like CABG or a valve, you can have pulmonary endothelial dysfunction. There's exposure to protamine, there's bleeding, there's blood transfusion, and all of these can increase the risk of postoperative right ventricle failure. Similar risk factors that we see with post-LVAD right ventricle failure as well too. So it's important to be aware that what we do to get a patient transplanted actually may have some deleterious effects. So isolated right ventricle dysfunction, you would suspect it when the central venous filling pressures are elevated, CVP to the wedge or LA pressure as well, elevated with low output, low mixed venous. Most of these patients, you will not have to wonder what their mixed venous is. We use pulmonary artery catheters to monitor their true PA sats, and you put these together and come up with the diagnosis of right ventricular failure. And once we diagnose this dysfunction, we have to pay close attention to the filling pressures, CVP, RV-EDP, output index. Echocardiography plays a very important part in assessing cardiac mechanics and optimizing cardiac mechanics as well. And we would hope that the interventricular septum is centrally aligned, not bowing into the left ventricular cavity. And we would use therapies to optimize filling pressures, including how do we manage volume, inotropic management, judicious ventilator management, which we would get to shortly, and inhale therapies as well to support the right ventricle and offload the pulmonary vascular resistance. And most patients typically would receive inotropic support. The heart is typically denervated, and a lot of times the heart rate coming out would be 90 to 110 beats per minute. And if that's not achieved, we will try to achieve that for physiologic reasons, which we'll go into shortly. And then this support is typically weaned over a few days, 2 to 4 days, up to 7 days at times as well, depending on how the patient progresses. But most patients with primary graft dysfunction of some form or fashion in the mild range can be handled conservatively with inotropic vasoactive medications, including adjunctive inhaled nitric oxide, which our center uses over prostacyclin. These are particularly useful agents because they give you selective pulmonary vasodilatation, optimizing the RV afterload on right ventricle to pulmonary artery coupling without the effects of IV therapies such as systemic hypotension. Now, in the case of severe right ventricular dysfunction or graft failure, we have to consider utilizing early mechanical support as it's indicated. This table here kind of shows us the classification. When you look at the grade, there's mild, moderate, severe down on the left-hand side. And on the top column, you can either be left-sided predominant or biventricular, right ventricular predominant. On the level of support, intuitively, the sicker patients would require mechanical support. And like in our case, our clinical scenario, this patient was on 0.25 of milrinone and low-dose vasopressin. So he would have been considered to have some mild primary graft dysfunction with some mild vasoplegia. To understand the hemodynamic phenotype or profile of the patient, most of these folks would have some type of postoperative vasoplegia, which is a reduction in vascular tone, similar to seen after cardiopulmonary bypass for CABG and valves. It's postulated because of this inflammatory response and dysregulation of the cyclic GMP-NO pathway. And there are risk factors. Some patients have mild vasoplegia on low dose one agent, and some would have severe vasoplegia requiring higher dose of multiple agents. And risk factors would include older recipient age, being on LVAD support for a prolonged period of time, having impaired renal function. Cardiopulmonary bypass time is associated with vasoplegia. The longer the pump run, the more exposure of the and extracorporealization of blood, and more inflammatory the cascade, and also prolonged ischemic time. It's just contextually you can stratify your patients, right? How do we treat this? You titrate the vasoactive medications to improve tone, restore adequate perfusion pressure, and the conventional guideline on mean arterial pressure of 65 millimeters of mercury. Many institutions use norepinephrine, vasopressin. Some institutions use angiotensin II, dopamine, low-dose epinephrine titrating up. And in case when it becomes refractory, one can consider methylene blue or cyanocobalamin, as has been used in more severe cases. As our patient was just on 0.02 units per minute of vasopressin in the clinical scenario at the beginning, we did not have to worry too much about adding other agents. This will segue into talking about the heart rate, because the heart rate, you need to get accustomed to what the autonomically denervated heart would do. And our patient's heart rate in the clinical scenario was 110, which is not uncommon to see and which is very appropriate. To have a sinus tach at 110 is very, very useful for the patient's hemodynamics. But you can have sinus bradycardia. You can also have SVTs and rhythm disturbances after heart transplantation. And it's important to understand how to treat it and also what that signifies. The heart rate of 100 to 110 helps the cardiac output because most of these grafts have diastolic dysfunction from ischemic reperfusion injury, for example, and maintaining AV synchrony and a more elevated heart rate helps the hemodynamics. So what would happen if your heart rate was a sinus at 60? You have some sinus node dysfunction, or if you were in a junctional rhythm. Well, what we would typically do is restore AV synchrony by atrial pacing if AV node conduction is intact, or we would pace you with a DDD mode to have A-pace, V-pace physiology at about 90 to 110 beats per minute. Now, if you have persistent tachyarrhythmias, for example, atrial flutter, one have to consider is the possibility of rejection. And that's just a little pearl that, you'll have to look out for in the, weeks to months after transplantation. Conduction abnormalities are not uncommon. The AV node conduction disorder can be seen affecting more than 10% of heart transplant patients. It's not really common for it to be permanent and requiring a durable pacemaker, but we can see it in the short term associated with longer surgical times, biatrial anastomotic technique. But what we would do to maintain synchrony, as I said previously, we would AV pace you through the epicardial leads. And when you see this done at the bedside, you would see how friendly a maneuver this is to their hemodynamics, their cardiac output, their cardiac index. You really need that contribution to stroke volume from the atrial kick. And now, according to many prestigious governing bodies, if you have persistent symptomatic bradycardia after a few weeks after transplant, it may be an indication for durable pacemaker. Although in my previous practice in clinics, less than 5 to 10% of patients of our total population of heart transplant patients really had a durable pacemaker. And out of those, many 6 months after were not pacemaker dependent. That's an interesting fact. And when the pendulum swings to tachyarrhythmias, as I said, you got to consider rejection. The numerous options to treat elevated heart rate must be used with caution. For example, beta blockers, calcium antagonists, and adenosine, and amiodarone as well too. So amiodarone and calcium antagonists, you have to be careful when optimizing your calcineurin inhibitor levels because of the interaction. And one also has to be careful with using adenosine post-transplant. I almost never used it, maybe once in every 3 or 4 years, and it would be a very reduced dose in a very controlled setting. Some guidelines would recommend if you're above 60 to 70 kilos, 1.5 would be the dose versus 6 milligrams in the regular adult non-transplant heart. But as I said, it's not a tool that I reach for frequently. There are many other methods that can be used. And a couple nice references at the bottom of each of these slides that would go into detail on these concepts. As I said, I want to make particular mention of the right ventricle and management of RV dysfunction and pulmonary hypertension. One would have to optimize preload, contractility, reduce the pulmonary vascular resistance, or RV afterload, to enhance RVPA coupling and cardiac output. And this would include inotropic support, inhaled pulmonary vasodilators, nitric oxide being the go-to in many institutions I've worked at. One would have to understand mechanical ventilation and the balance of pulmonary vascular resistance versus lung volume curves, which I will show a nice cartoon of that. And one would have to consider mechanical circulatory support to bypass the right ventricle when it's indicated, more as an upfront versus a salvage therapy before any type of organ failure sets in. This will lead us into talking about acute kidney injury. And this is not uncommon after heart transplantation, as we also see it in after open heart surgery, after lung transplantation. The incidence is about 25 to 50%. But what's interesting is that the incidence of these patients requiring dialysis, fortunately, is much lower. I would say in the past 5 years, I would say around 10% or less patients when optimized would actually require renal replacement therapies, and even a less portion leave the hospital requiring dialysis. But what's the big deal? What's important about acute kidney injury? It's associated with reduced short-term and one-year patient survival, and in many critical care environments, AKI is an independent predictor of mortality in mixed population of patients. It's important to recognize and try to intervene early and appropriately. And there are numerous risk factors that would contribute to that, as most of the audience would have come across. Hemodynamic swings, very common during cardiopulmonary bypass, weaning from bypass, volume shifts, right ventricular failure, and venous congestion, just to name a few. And how does it tie in? You know, acute kidney injury on the right ventricle, we could get into a vicious cycle here, because if one goes into a right ventricle failure, become refractory to diuretics, they may very well need renal replacement therapy. And in my practice and our group, we would have a low threshold for instituting renal replacement therapy. As non-oliguric renal failure, it can really progress to anuria very swiftly. This can happen within hours. And one has to be aware that reduced urine output, venous congestion can lead to this vicious cycle of right ventricular distension, worsening tricuspid regurgitation, worsening RV systolic dysfunction, reduced effective forward cardiac output. And this elevated right atrial pressures would lead to hepatic congestion and, worst case scenario, decompensating liver failure. So one has to be very aware that when trial of diuretics is instituted, if it is failing, one should not wait, should have a very low threshold potentially for renal replacement therapy when indicated, because of this vicious cycle that can occur. And we move from right ventricle dysfunction to a word on mechanical ventilation, because all of these patients go straight from the operating room to the intensive care unit intubated. Similarly, for open heart patients, anesthesia would generally not have the practice of extubating. They would come to the ICU intubated. And it's important to note there's no standard evidence-based mode of mechanical ventilation. Different institutions use different modes. The goal is lung protective ventilation, and that should really be the governing principle of our practice in critical care in general to have judicious lung protective ventilation to reduce the chance of acute lung injury. One must understand ventilator dyssynchrony and the very negative effects on cardiac mechanics. And one has to consider the effects of atelectasis on the right ventricle and PVR. And I'll show you a graph on that. That's very important when it comes to weaning and liberation from mechanical ventilation. One cannot come off the mechanical ventilation without thinking about weaning nitric oxide and making sure the right ventricle, left ventricle is stable. And then we would talk about pressure support and extubating to high flow BiPAP. I want us to understand most of these patients, post-operatively would come out, would have good gas exchange. You'll get their oxygenation, optimize their FiO2 down to 40%. Their chest X-ray would look nice and clear. And the majority of patients will be able to pressure support and be extubated to high flow without any issues. What we have to be very good at is when we have moderate to severe right ventricle dysfunction and or left ventricle dysfunction with elevated LVEDP and pulmonary edema. How does one safely get a patient extubated? I think a lot of understanding the effects of lung volumes would have to understand this curve with the vertical axis showing PVR and the horizontal axis showing lung volumes. And the intraalveolar vessels, as you can see, as the lung volumes increase, you would see the PVR go up, and the extra alveolar vessels, as the lung volumes increase, this blue line, you'll see the PVR decrease. Now, the net effect of this is a combination where you get this nice U-shaped PVR to lung volume curve, and you want to be somewhere in the middle, where you have this optimal lung volume and you have the lowest PVR that you can get. The point of understanding this is if you remove positive pressure prematurely and develop atelectasis, you can have increased PVR. And if you over-distend the lung with PEEP air trapping, you can also have elevated PVR. And that's tolerated well in a normal native heart, but fresh cardiac allograft may run into negative effects such as low cardiac output, cardiac index with venous congestion. So this might be one of the most important graphs when managing cardiac mechanics and mechanical ventilation. And this cartoon from published in JACC called Positive Pressure in the ICU, it really tells you what is happening on the right ventricle and the left ventricle when we use PEEP positive pressure. And this paper here would highlight the physiology of the right ventricle, what happens when we have PEEP versus the left ventricle. And I would not go into it in great detail, but one has to find this perfect balance. That's what the seesaw is, where you would not have a decrease in cardiac output, venous congestion. You would have either normal or increased cardiac output just by balancing, as you saw in this curve previously here, the contributory effects of being at the functional residual capacity versus over-distension versus atelectasis. So this kind of guides you that if somebody had, say, for example, a predominant left ventricular dysfunction, what would happen with PEEP and positive pressure, the preload, how it would affect the preload, how it would affect the LV afterload as well, and in effect affect the cardiac output, cardiac index. So this is a very high yield slide that I thought was worth including. And now let's just move on to something that we should not lose focus on. This is easy because elevated blood sugar does not cause the patient any pain immediately, does not cause any changes in their pH, in their blood gas, in their cardiac output, in their cardiac index, but it is easily overlooked, and we really need to focus because hypoglycemia is present in majority of cardiac surgical patients, all comers, and it is associated with a worse outcome. But what would these outcomes be that should make us so concerned? Deep sternal wound infections, associations with AKI, perioperative mortality, and all comers of cardiac surgery, and in fact, heart transplantation, patients with sternotomy are not spared from this effect. So a lot of institutions have come up with very strict IV insulin-driven protocols. Some institutions target 130 to 160. Some institutions target 140 to 180. But we all have to accept the fact that the driving factors for hypoglycemia are going to be present in a lot of patients. And stress-induced catecholamine and corticosteroids are very common driving factors. And in fact, if they're diabetic or pre-transplant, it increases their risk. But observational and randomized controlled trials within cardiac and non-cardiac patients have shown that a level below 180 is recommended by most scientific societies. But as I said, many institutions have worked at targeted 130 to 160, and that gave a window such that if the sugars were to be elevated, they definitely will not pass in 180 to 200. So those spikes that can frequently occur, especially if there's any acute stress or changes in the patient condition, dosing of steroids, that those will be basically under control. And for those of us who've taken care of deep sternal wound infections, especially in diabetics, it gives the patient a protracted, very negative clinical course, and it really reduces quality of life as well. In addition to increasing hospitalization, need for antibiotics. So if we can do something up front, in my belief, to prevent this clinical course, especially when it's something could be protocolized and driven, such as IV insulin, and then transition to basal, bolus, slide, and scale, I think it's something worthwhile that institutions explore. Let me go forward. We can't forget antibacterial prophylaxis, as most skin wound infections around the chest tube site would be staph-driven, coagulase negative or Staph aureus. And, there's a lot of data out there on how do we prevent wound infections, whether it's cardiac surgery or GI surgery, thoracic surgery. But institutions typically would do vancomycin with a first-generation cephalosporin. But the point of talking about this is that we should not have a one-size-fits-all. We should do more individualized, precision-based medicine. And we have a lot of patients who get heart transplants off of LVAD, off of devices, and the prophylaxis should target the patient's implicated pathogens. For example, if they were colonized or infected with a resistant bacteria in the past, we cannot just ignore this when it comes to prophylaxis. And we should also look upon the duration dependent on the extent of infection. A special consideration in the setting of open chest, when patients have to, they'll be open, packed, and have to go back to the operating room for washout. It's been our practice to keep the antibiotics broad coverage, including considering gram-negative coverage up to and 72 hours after chest is closed. Some programs extend this for up to a week as well, too, depending on the patient population. I do think most programs would have to focus on more individualized care of these patients. Let's advance. Now, the job of the intensivist as well, too, when receiving a patient is to stratify risk for infection, and most commonly to stratify intermediate or high-risk CMV status and make sure they're on the appropriate therapies. Special mention that, use of antiviral prophylaxis for EBV is still conflicting and very much institution dependent. And I've worked in about 3 or 4 transplant centers. Everywhere has a little bit of a different protocol, but when it comes to CMV, there's almost a across-the-board agreement of it. Unlike prophylaxis for Candida, antifungal prophylaxis, there's a low incidence of invasive candidial infection following transplant. So a lot of programs don't target in particular anti-candidial prophylaxis, but more so anti-aspergillus prophylaxis as well. But one has to understand the risk factors for invasive aspergillosis, airway colonization, patients post-transplant hemodialysis, ECMO, CMV disease. And it's important to understand programmatically that if any patient develops invasive aspergillosis in that program 2 months before or after the date your patient's transplanted, one has to consider that this patient would be at risk and may need extended periods of prophylaxis versus truncated treatment and then developing a pretty severe infection. Also want to mention in the realm of antifungal prophylaxis that pneumocystis incidence is highest within the first 6 months of transplant. And depending regionally, some places will not have to consider coccidioidomycosis, but with an incidence that could be up to 7%, one would have to follow the institution-based protocols. Also, the travel history of the patient, if they resided in an area where that was endemic and transplanted in a different center, it would be particularly important to reach out to your transplant ID colleagues and decide if one should have prophylaxis against coccidio based on previous exposures. Antiprotozoal in terms of Toxoplasma gondii, greatest concern with a mismatched donor positive, recipient negative. And again, most institutions would have anti-toxo gondii protocol for the drug of choice that's available and the duration as well. And last but not least, I do want to mention that the treatment of congenital patients has become so optimal that a lot are making it into their adult careers and will require advanced therapies and cardiac transplantation if they meet the criteria. And the Fontan patient is one that I think many programs across the US, specialized referral centers may encounter. And the population will continue to grow, and it's very important to understand there are certain caveats of the Fontan patient, and this can be entire lecture by itself, but most of the time, the failing Fontan would have elevated venous central pressures as well as a low cardiac output cardiac index, and they would present and transition from the adult congenital service to the advanced heart failure service for evaluation of advanced therapies. And the problem and the disadvantage of these patients is that we have seen delays in referrals. We've seen progression of FALD or Fontan-associated liver disease, which can present with cirrhosis, rendering the patient no longer needing just a heart transplant, but a combination heart-liver transplant. And we have had good outcomes in experienced centers in the United States with doing heart-liver. But it would be great to capture these patients before progression of Fontan-associated liver disease. Now, the perioperative management of Fontan patients would really require understanding their pre-transplant conditions that can persist, albeit improve with time after heart transplantation, such as protein-losing enteropathy and plastic bronchitis. And those can have exacerbations in the early postoperative period and require specialized therapy. Presence of AP collaterals or aortopulmonary collaterals post-transplant. There have been reports of high output cardiac failure and high output situations early in the postoperative transplantation course. And a couple institutions that I have not worked at these, but colleagues of mine, they would preemptively try to address these aortopulmonary collaterals prior to transplantation because of their experience with how it affects them in the post-transplant course. But all in all, I think the Fontan patients would be a bit challenging nutritionally, a bit challenging even from a coagulation standpoint if they have Fontan-associated liver disease, but not end-stage cirrhosis. And from a plastic bronchitis standpoint, they could be disadvantaged, requiring very aggressive respiratory therapies in the early post-extubation period. And I think it's worth having some experience with Fontans. And we touched on that clinical scenario. We touched on hemodynamics, including heart rate and rhythm, right ventricle and pulmonary vascular resistance, acute kidney injury, mechanical ventilation, the interaction between the RV and acute kidney injury, glycemic control, antibacterial, fungal, viral, protozoal prophylaxis, and a word on Fontan. And this is the nuts and bolts of the management of heart transplantation patients in the intensive care unit. And I'll be happy to take any questions.
Portive heart transplant.
Professor.
It's very comprehensive. You touch all aspects. We asked Dr. Breda for the highlights of your talk. If Dr. Breda, please, we are waiting for your highlights of this excellent presentation. I think you work in a good company in your institution with Kadhir and others. Your mic is off.
Oh, sorry. Thank you.
You're muted.
So, good afternoon, everybody. First of all, I would like to thank you, Sage, for this great presentation. Thank you so much for accepting our invitation and be here with all my Brazilian friends that I told you before. And I would like to say that Sage is, besides the fact that he is a great intensivist with experience in cardiology, in echocardiogram, he's a very good friend. And he's a great person. I had the opportunity to meet here in Miami. We have been working together mostly for the past 2 years. And we have a great partnership. I would like to highlight first that we are in charge of a shock team program development, cardiogenic shock team program development. It was his initiative, and he has been working a lot on that. So thank you so much for everything, Saji. But I will switch to Portuguese now to make some comments about your presentation. But I am pretty sure you are getting more and more used with that, because we already attended some barbecue parties with our Brazilian friends here, and you know how it is. So I know you are practicing your Spanish. Next step is going to be you to learn Portuguese. I told you that before.
I appreciate it. Thank you, Dr. Breda. Thank you, João.
Bom, boa tarde a todos. Obrigado, professor Walter, professor Nelson, professora Solange, mais uma vez. E quando eu conversei com vocês sobre essa apresentação, na verdade, como o professor Walter já falou, ele fez um apanhado geral sobre o que é importante quando o paciente pós-transplante cardíaco chega no pós-operatório imediato na UTI. E eu não quero repetir a respeito das coisas médicas teóricas que ele apresentou. O que eu queria chamar a atenção é que isso é uma coisa extremamente importante. Como nós estamos vendo durante todo esse nosso curso de atualização, o transplante cardíaco é um dos tratamentos, é uma das práticas da medicina e da cirurgia cardíaca que, obviamente, já ficou claro que é impossível para um indivíduo, para um grupo, para fazer. É necessário um envolvimento de várias pessoas, de vários especialistas, com expertises diferentes. E o ponto com o intensivista, principalmente como no caso do Saji e de outros intensivistas que trabalham conosco aqui, é o fato deles serem especialistas do ponto de vista cardiológico. Aqui nós temos intensivistas pneumologistas, intensivistas de outras áreas, que vêm do departamento de emergência, mas para nós é muito importante ter esse intensivista com foco cardiológico. Por que eu estou dizendo isso? Porque vocês todos os cirurgiões e todo mundo que trabalha com transplante sabe disso. Para nós, cirurgiões, é um procedimento que demanda muito da nossa capacidade física. É um procedimento que, normalmente, na escola paulista, a gente brincava, né? A partir do momento que a gente sabia que havia um doador que havia sido aceito, provavelmente a gente só ia embora 12 horas depois, no melhor cenário. Isso porque existem muitas coisas envolvidas, é o doador, é o receptor e etc. Então, o que eu quero dizer com isso é, normalmente, quando a gente termina o transplante cardíaco, a equipe cirúrgica está extremamente cansada, está esgotada. Fazer o pós-operatório imediato desses pacientes é uma coisa que demandaria muito. Então, é muito importante essa participação do intensivista. É claro, eu costumo dizer o seguinte, eles só não vão operar, eles não vão tratar ali o sangramento, uma revisão de hemostasia, se precisar reabrir o tórax do doente, mas o resto, a gente precisa da participação desses indivíduos. E mesmo quando nós temos intercorrências que necessitam do tratamento cirúrgico, normalmente, quando eles nos chamarem de volta, a gente já tem o diagnóstico definido, eles já tentaram compensar o máximo possível clinicamente o paciente, e você vai ter que atuar na parte cirúrgica. Se não for isso, você tem que contar com esse especialista para te ajudar. Não estou dizendo que o cirurgião não vai participar, é óbvio que vai participar, mas é muito importante ter essa participação do intensivista. No nosso caso aqui, como eu disse a vocês, eles são cardiologistas, eles têm experiência com ecocardiograma, transtorácico, transesofágico, o que permite uma avaliação completa desse paciente quando ele está lá na unidade de pós-operatório. Então, o ponto que eu queria trazer hoje não é relacionado à insuficiência renal, choque cardiogênico, infecção, nada disso. É a importância dos programas de transplante cardíaco, de identificar essas pessoas com essas expertises para atuarem em conjunto com todo o grupo para um melhor resultado final. Então, esses seriam meus comentários. Obrigado.
João, thank you very much for your comments. Kadhir, João, he scrutinized very well your talk. But we have some questions from our audience. The first one is related about the regime of immune suppression in your institution. Could you tell us a few words about your regime in immunosuppression, please?
Sure. This immunosuppression regime in Miami is pretty similar to a couple other institutions I worked at, where we do what you call a Simulect, a basiliximab induction, lymphocyte sparing on day 1 and 4, Medrol, which is the steroid arm, and then we would also have Cellcept or mycophenolate. And using basiliximab on day 1 and day 4 allows us to have a delayed start of tacrolimus, which has a kidney sparing effect. So we could push that out a few days, make sure the kidney function and hemodynamics are stable prior to starting tacrolimus or FK. So the maintenance regime would involve either IV Medrol or prednisone, Cellcept or mycophenolate, and tacrolimus as well too. And that's pretty much what we do for the heart transplant patients.
All right. Thank you. But we have another question from the floor. It's related to the myocardial biopsy. What's your schedule for myocardial biopsy? And what do you do if it's positive, if you have a rejection? What do you do in your institution?
So we have a regime, Q weekly myocardial biopsies in the short term, then it goes to Q2 week. And we would use the ISHLT grading for acute cellular rejection, 0, 1 hour, 2 hour, 3 hour. And on the same day of biopsy, we would get an echo for 2 reasons. One, we'll look at the cardiac function in relation to the histology, and we'll also look for any effusion, which is uncommon to have after biopsy. 0 and 1 hour in particular, without dysfunction, we would not treat. 2 hour and 3 hour histologically, with or without echocardiographic dysfunction, we would have to optimize the steroid regime and treat aggressively. Fortunately, most of our patients, with the Simulect induction, the high dose Medrol that we give, we get 0 or 1 hour acute cellular rejection on the biopsy. Post transplant, 6-12 months later, we've seen anything from 2 hour, 3 hour, in addition to acute humoral rejection as well too, that requires plasma exchange and optimization.
Thank you. Another question is, what's your threshold to call John midnight and you are not yet in control of the patient?
Mm-hmm. This is a great question.
To call surgeon. What's your threshold for that?
So this is a great question. I think it's very important that we define the hemodynamic phenotype and have a baseline assessment of the trajectory. Much like any patient in cardiac surgery, I would tell the team and myself that we would have to say, hey, what level of shock do we have? What level of graft dysfunction do we have? What intervention are we going to try? And at what point, what defined point will we say that this intervention is not working? For example, let's suppose we have moderate right ventricle dysfunction on milrinone, like our patient in this scenario, and the central venous pressure was 15, urine output was decreasing, and we made a decision to add dobutamine or another ionotrope and to give a diuretic challenge. Our plan before we leave the bedside would be in 1 hour or in 2 hours, we would have a repeat lactic acid. We would look at the urine output. We would look at the SWAN numbers and the echo, And if the patient's staying the same or getting better, we will not escalate to right ventricle mechanical support. But if there's any deterioration, for example, CVP going up, anuria, mixed venous is going down, the lactic acid is not clearing, the patient is now in tachyarrhythmia, we would want to go early before worsening kidney failure, hepatic congestion, which in my opinion, if we go into fulminant liver failure, we've missed the opportunity. So this would be an hour by hour assessment with very effective communication and a defined path. Because if we say, hey man, let's talk about this tomorrow, the CVP is going to be 20, there'll be anuric, the pH will be 7, we'll be on 3 drips, the AST, ALT will be in the thousands. And unfortunately, we've received patients like that from other hospitals when the mechanical support is salvage instead of upfront. So I make a plan from before, such that if I call Joao at 10 p.m. or 2 a.m., he's not surprised. If the phone rings, it's because we have gone down the path of failing medical therapies.
All right. Nelson, do you have another question? Joao?
I have, Walter. Congratulations on your presentation.
Thank you.
It's really difficult to compile such a broad topic. Imagine you have a patient that is experiencing a severe RV dysfunction, regardless of the presence of rejection, and you decide you have to escalate for RV assisted mechanical device. What is your rationale to refer this patient to VA ECMO or central cannulation? Do you have a protocol?
So yeah, this is definitely a nice question, and it's very much echo guided, because if we have isolated right ventricle failure with well-functioning LV on inotropic support, we have two options. We have full VA ECMO support, or we have a percutaneous right ventricle device such as the Protect Duo. We don't use the right-sided impeller right now. I don't believe that will unload the RV well enough. But I think it would really depend on what the left ventricle would do. Because if we have moderate or severe LV dysfunction and we go on VA ECMO, we will indeed require an LV vent. And a lot of times we have to look at the patient with real-time echo. We do have a shock algorithm that kind of defines the workhorse using cardiac power output and PAPI, and what kind of devices we would use for LV, RV, or biventricular failure. And it's taken from a nice expert review from Journal of Cardiology, actually. But I think we've seen this be very dynamic, that the decision will be guided by bedside, transesophageal, or transthoracic. And I've encountered both phenotypes where, you have to just go on full VA ECMO support, offload the right ventricle, optimize the volume status, optimize the rhythm, optimize the gas exchange, the atelectasis, the acute lung injury, and then attempt to wean the patient off. And again, that's not the majority of heart transplant patients. Joao and I had one probably last December that we did a RA to PA bypass. And, it's probably less than 5-10% of patients that we actually have to do robust right ventricle mechanical support for. But it's a challenging question, because I have done Protects on the right side only to have LV dysfunction, pulmonary edema requiring an impeller 5.5 on the left side. And in hindsight, the team would say, why didn't we just do VA ECMO with a balloon pump to vent the LV, or percutaneous impeller? But as I said, we make the decision with real-time echo and SWAN data. Joao, any comments on that? Because I defer to their expertise a lot at the same time.
Yes, no, that's a very, very important question also. And it brings a lot of definition, because it's not easy to decide about the best mechanical support for the patient. So it's case by case. That's for sure. The last case that we had, it was 1 week ago. The patient had a complicated PCI. The patient crashed during the procedure. The intervention of cardiologists, they put the patient with impeller CP and impeller, and he was transferred to us. When he came and when he arrived here in the hospital, we were able to see that the support was not adequate. the patient was getting worse. As Sage brought your attention, lactate trending up, patient becoming anuric, things like that. So for sure, we need escalation on mechanical support. In this particular case, we decided to remove the Impel RP and we put the patient on VA ECMO. And we decided to keep the Impella CP as a vent. But we had a lot of discussion if we should escalate for an Impella 5.5 in the axillary artery. But in this particular case, it worked very well. And the patient did fine. He recovered completely the function. He's still in our step-down unit. He's about to be discharged from the hospital. So that's a very, very important question and a challenging one. Because when you have a lot of, not a lot, but you have some options, it's sometimes you need to try to tailor the patient, the case, and everything to the support that you are indicated. So it's very, very important to your question.
Yeah, I was gonna reinforce what you just said, because it's a very complex clinical scenario that we can have one fixed algorithm to treat all patients. That individual management must be tailored to the patient. It's a complex setting. Thank you so much.
And that's the importance to have a team to make this decision, because it's very hard. So usually, as Walter called our attention, it's usually Friday night, Saturday early morning, Friday night. So, and if you are alone there to take these decisions, it's not easy. Saji and I, we are used to go to bedside to see the patient. It's a very hard job because sometimes the patient doesn't require any support. Saji, a lot of times Saji was there doing critical care for this patient. Like the other day, he made a diagnostic of sepsis and treated the patient, but medically, and the patient did well. And didn't require any mechanical support. But to take this call alone, it's very hard. So that's, again, it's very important to work in a multidisciplinary team to share your decisions. That I think is the most important message to treat so complex patients.
Absolutely.
Any further questions? I think not from the audience. Then I would like to thank you, Saji or Kadhir. What's a very, very instructive talk and discussion as well. Excellent talk and very comprehensive. I'd like to thank you again, Kadhir, for this talk. And hope meet you in the future for the next course for heart transplantation. Thank you very much.
Next time you should invite him to go to Brazil to try barbecue with us there. We did some barbecue here, but it's not the same.
He'll be all invited for a good barbecue. We hope to host you in Brazil next time.
Appreciate the opportunity, guys. And, you know, João has my contact. I'm always available for questions. And I think the opportunity to be involved in education is one of the main reasons we are in this field, in addition to help patients. And it's a fantastic opportunity. I say, thank God to meet the team and to be able to be part of it. And I look forward to the next one.
Okay. Thank you very much.
Thank you.
Bye-bye.
Somos a Unifesp, Universidade Federal de São Paulo, e temos a missão de defender e expandir a educação pública, gratuita e de qualidade no Brasil. Atualmente, a Unifesp possui 7 campi. No campus São Paulo, ficam a Escola Paulista de Medicina e a Escola Paulista de Enfermagem. Na Baixada Santista estão o Instituto de Saúde e Sociedade e o Instituto do Mar. O Instituto de Ciências Ambientais, Químicas e Farmacêuticas está localizado em Diadema. No campus Guarulhos, localiza-se a Escola de Filosofia, Letras e Ciências Humanas. Em São José dos Campos está o Instituto de Ciência e Tecnologia. No campus Osasco, localiza-se a Escola Paulista de Política, Economia e Negócios. O Instituto das Cidades é o mais novo da Unifesp e está localizado no campus Zona Leste. A Unifesp é para todos. Universidade pública, gratuita e de qualidade.